So, as you were saying, there's a lot that one is losing when one perceives that they're losing when they're faced with a diagnosis like that. I don't know which to choose. I guess I'll take this one. When they're faced with a diagnosis like that, and it's not just the person who is diagnosed with Parkinson's, it's their entire system that can sort of feel this perceived loss.
Maybe a little louder, Rocky. Yeah. We can turn up her mic a bit.
So it's their entire system that can feel this perceived loss. So it can be really helpful to talk to a professional about what you are feeling like you're losing, what life might look like for you in the future, and redefining oneself, not just the person diagnosed with Parkinson's, but also their system. Is that an answer to your question?
Okay, so we're going to move into our next section. We'll be back for questions again, so hold your questions. So we're going to talk a bit about goals and types of treatment in Parkinson's disease. And it's important again to remember, as we talked about, there isn't a cure for Parkinson's disease per se. So treatment of Parkinson's disease remains treatment of the symptoms. And there's no treatment that has been proven to provide a modifying effect to slow the disease down or change the course of the disease. Also, there is no drug that we have or intervention per se that can prevent the disease, although there is some research suggesting people at risk for Parkinson's, a first-degree relative, those that exercised had a decreased risk of developing Parkinson's disease. And you know my focus on exercise in all areas of the disease. It's important when we think about goals of treatment to take into account these four areas: the time of onset and the duration of disease. So sometimes Dr. Alvarez and I will see a patient who is very early and newly diagnosed. Other times we'll see patients who perhaps didn't receive a diagnosis and are later in the course, or received a diagnosis and received a certain amount of treatment to date. So we take into consideration those two things. The age of the patient also needs to be taken into consideration. Certain interventions are more appropriate for younger patients versus older patients. As you know, most drugs are never studied in individuals over the age of 80. They're just not included in most drug studies because of the risk of side effects in that age group, and so drug companies typically exclude patients over 80. So it's important to take age into account. The potential benefits of the intervention, so the risks versus the benefits, and of course short and long-term side effects that may be part of that treatment. So the aim of treatment is to support self-sustainment in activities of daily living, to try to maintain the individual to be able to do the things that they need to do in life. Those are the guideposts of treatment. Can you do what your day requires? And that day is different from patient to patient, situation to situation. And so that has to be very individualized. And if you discuss what you're taking with the other individuals on your table, I suspect none of you will be on the exact same regimen, even if you're seen by the same physician, because it has to be very individualized. The second goal is to reduce or prevent disability and the need then to be supported. All right, so we may not be able to reverse all the symptoms, but we want to try to reduce the risk of making the symptoms worse by doing things that put the patient at risk. So we want to preserve independence and social competence both within the family and society, and in some instances try to maintain the capability of work. So patients want to continue to work. They get benefit from working, not only financially, but insofar as their thought processes, being part of society. We want to try to maintain that in certain instances. And then also maintain or regain health-related quality of life. Of course, quality of life rather than just treating the symptoms. So we want to limit secondary complications, this to be a minimum in the course of the disease. And these are two broad areas. orthopedic that I'm going to get Dr. Lee to answer a question after this part on orthopedic fractures and injuries in Parkinson's disease. And of course, other medical problems resulting from things that are under our control. And Dr. Alvarez and I talk about this almost in every visit. So things that are under your control, at least partially, but maybe more than partially, is reducing the incidence of obesity and what obesity can lead to, diabetes, other medical problems, obesity-related cancers that can then cause those soldiers to have to go and fight that part of the disease and not stay focused on Parkinson's disease. Poor diet that results in constipation, other health issues, and we've already talked about inactivity. So when you think about Parkinson's disease treatment, there is this pyramid that I showed last time we had this meeting, and I want you to remember it well. So the foundation of treatment is always exercise, whether that be physical, occupational, speech therapy, other exercises, gyms, Pilates, other things you might choose, and diet. And we all know when we don't build a home with a strong foundation, everything you put on top of it becomes leaning, cracked. We can't close the doors. That's what happens in Parkinson's disease. So if you don't have a strong foundation, the rest of treatment is going to work less well. So the immediate effects of exercise, of course, are to increase walking speed, longer stride length, better balance. But the long-term effects have effects in maintaining balance, your ability to move, your daily activities. And when individuals do therapy or exercise, it's associated with a better sense of well-being across all stages and severity. And there are multiple studies that have shown exercise to be as useful as certain antidepressants to treat depression, anxiety, other mental illnesses. And so it's important not only in constipation and sleep, but also mental health. It also lessens the risk of falls and other complications. And so we see this across the disease state. So there's been a study that I frequently like to cite in clinic that patients who experienced exercise of 2.5 hours, 150 minutes per week, showed a slower decline in quality of life. And the sooner they began that, the better throughout the course of the disease. And so 150 minutes, 20 minutes a day, 30 minutes 5 times a week isn't asking a lot. Just think of how often you take a pill. And we're asking for 20 minutes once a day or 10 minutes twice a day. This needs to be considered the foundation of all of your treatment. And animal studies have shown that when the animals exercise, their brain cells use dopamine more efficiently. So rather than eating dopamine, exercise and use the dopamine you make more efficiently. So there's less of that transporter. That means the dopamine stays around longer to act. There's more places for the dopamine to bind where we want it to bind and do its job. And these places for dopamine to bind are reduced in obesity. So not only lack of exercise, but obesity reduces the places that dopamine can work. So many lines of evidence to facilitate your incorporation of exercise. And I'd like you to think of fitness as getting fitness insurance. We all buy car insurance, we buy homeowners insurance to soften the blow should something happen. You need to buy fitness insurance, and that's wellness and beyond wellness, being fit, so that when you do get back pain, or when you do get a urinary tract infection, or perhaps pneumonia, you've built up this fitness insurance so that you can combat that decline, temporary decline, hopefully, in your overall ability to do what you need to do. And so you need to have that fitness insurance as part of your approach. So this is my favorite phrase, sitting is the new smoking. So you need to think of inactivity as we were thinking about smoking. And so get off the chair and walk around. And I'm told by Tony that this is a good time for for us to have one of our therapists lead a short exercise routine here in the middle of this presentation. So let's all find...
And quickly, for those of you who are trying to snap pictures of the slide, just like last year, the entire deck from today, as well as the entire video coverage from today, will be on the website again this year.
All right, so let's follow Kathy here.
I'm going to ask my power certified friends in the audience. I know there's more experienced people, and I know we have UIW students, and Melinda. If everybody could kind of spread out throughout the room, so if anybody needs any help, we're just going to do a quick power up exercise that's for standing, okay? So if you can do this sitting, I'll show you both ways, okay? Melinda, you want to do the stand power up, and I'll do the sitting power up to show them? So I'll kind of lead it.
We're going to follow Kathy and Melinda here.
Big movements going through your entire range of motion are very important with Parkinson's, and this can help. I do have a big mouth. Not quite as big as Tony's, but I'm close. So going through your entire range is very important. Big, powerful movements. We can talk more. I'd like to talk later more about the elements that your exercise program needs to include, but for now, we'll do this power-up exercise. So I'm going to demonstrate the seated version. Melinda's going to demonstrate the standing version, and we'll kind of go through that. So the seated version, can't sit like a lady. Good thing I didn't wear a skirt. You're going to sit with your legs apart in your chair. Scoot to the front edge of your chair. Melinda's going to stand with her legs apart.
And if the salad people can just hold off for a second, and let's get through this 2 minutes.
And I'm going to have to put the mic down to show you this, so I'll be loud. I promise I'll be loud. Hands, thank you. Your arms are going to go on toward your knees, and then we're going to power up, and we're going to push up, and we're going to say power up, and you're going to extend your arms behind you, open your hands as widely as possible, and squeeze your shoulder blades together. Okay, so that's one. We come down and we say 2, big, extend the arms. And I see the people doing the standing. Watch Melinda if you want to do it standing. And then back, 3, and really extend that back and squeeze your shoulder blades together. Open your hands big and extend your elbows. Okay?
Okay, we'll do some more a little later, so salads can continue to be delivered. So. So on top of the foundation of diet and exercise will come the medications that we commonly use to treat Parkinson's disease. And you'll be able to refer to this graph online if you'd like to look at it more in detail on this figure. But it shows you the various places that the medicines we use can be useful in Parkinson's disease. And we're going to talk a little bit about these as you enjoy your very healthy meal from the review that we gave earlier. So in Parkinson's disease, there are a number of treatments that we use every day. So these medicines are used on a daily basis with the goals of what I just mentioned in treatment. And so we may use certain agents that prevent the breakdown of dopamine. So the dopamine that we make or the dopamine that we facilitate to make stays around longer. And so these agents, MAO-B inhibitors, I've listed the 3 on the slide: rasagiline, selegiline, safinamide. Those are 3 that inhibit the breakdown of dopamine, keep dopamine around longer. We may use these agents by themselves, or we may use them in combination with levodopa to improve the symptoms and the goals, and attain the goals that we mentioned. We most commonly use levodopa along with carbidopa. And we're going to talk more at length about levodopa later, but it is available in an immediate release form, an extended release, and a tablet and extended release capsule. Most recently, Rytari was approved. That is an extended release capsule of levodopa. In addition to those main agents, there are two other classes of agents that we may utilize either alone or in combination with levodopa. This includes the dopamine agonists, of which 3 are listed here that are available in the United States: Requip or Ropinirole, Mirapex or Pramipexole, and the dopamine agonist available by patch, Nupro. Rotidogene is also available for use. Now, the group of dopamine agonists may be utilized early in the course or as an adjunct later in levodopa, although we've tended to pull back on our use of dopamine agonists more recently because of some of the problems that we've seen associated with their chronic use. This is things such as leg swelling, compulsive behaviors, compulsive gambling, shopping, other things that may be a problem in certain patients' lives. So you might see that we've pulled back a bit in the use of these agents. Anticholinergics, including Artane, which we've heard earlier about, may be very useful in the treatment of tremor. And this we may utilize when tremor is the specific source of disability, and we haven't been able to treat it very well with levodopa. The problem with Artane is that it can not only cause constipation, as we've heard earlier, but it can affect thinking and slow memory processes in certain patients. These are reversible when you stop the drug, but certainly something to consider when using anticholinergics, specifically Artane. The last area of maintenance treatments include these two categories. So the catechol methyltransferase inhibitors, or COMT inhibitors. There are 2 on the market, although we only use one. This is the first one, the entacapone, COMT10, which is used generally with each dose of your levodopa, and it also inhibits the metabolism of L-dopa, and thus keeps more dopamine around longer. Tasmar is an agent that has been around for a long time, but is rarely used because of some of the side effects that have been associated with it, require certain monitoring. There will be a new COMT inhibitor, hopefully in the next 18 months. This is a once daily COMT inhibitor, opicapone, which is presently under review by the FDA. The last category of maintenance treatments include the amantadine drugs. We have immediate release amantadine, and then we have 2 extended release amantadines, Gocorbi and Osmolex ER, both of which are taken in a once daily fashion. So these are generally utilized for dyskinesias, the extra movements that can occur in association with the disease, and the treatment with L-dopa or levodopa. All right, in addition to the maintenance treatments,